We are about to start the post-lunch session, and welcome back. We have post-lunch plenary by Prof. Mahesh Nirmalan, who is a Vice Dean, Faculty of Biology, Medicine and Health, University of Manchester. And he's going to talk on evaluating the impact of post-conflict major limb loss in northern Uganda and its implications in Sri Lanka. Okay, over to you, Dr. Professor Nirmalan. Are you on?
Good afternoon, ladies and gentlemen. Chairman, respected teachers, friends, colleagues, ladies and gentlemen. It's a great privilege to join you all this afternoon. And when my good friend, Dr. Vijay Vikrama, approached me several months ago, asking whether I would do this talk, not even in my wildest of dreams did I imagine that I will be doing this talk on a cold, cloudy, wintry morning here in Manchester from my office room in my house. As many of you will know, I'm an anesthetist by training, and you might wonder, what is an anesthetist trying to do today, trying to talk about conflict and limb loss, etc. Now, I've selected this topic quite deliberately when Dr. Vijay Vikram asked me, and it comes with a health warning in the sense, I'm not a subject specialist in the topics that I'm going to speak today. But the reason why I selected this topic is to address some of perhaps the younger members of the audience, to say that one's professional experiences do not have to be in any way limited by the various labels that we put on ourselves, the ology label or whatever label we put on ourselves. Our professional experience should not be limited by those labels. There is a wide world out there for us to experience and enhance our professional experience. I think it is fair to say a historian who records the histories of the 20th and 21st century sometime later is bound to record many good events that took place. The discovery of antibiotics, the description of the theory of relativity, the man's journey to moon, and more recently, the discovery of the human genome code. A lot of good things did happen. But this period in our history also needs to be recognized as a period where there were so many conflicts between people who lived within the same country for whatever reason. Now, there's a generic pattern to most of these conflicts in the sense, what starts off as a perceived injustices, very soon is exploited by political opportunism, usually on both sides of the divide. And before one realizes, it escalates into a large-scale military conflict fought within densely populated areas. Now, when this happens, the consequences of this form of combat is almost predictable. And it leaves consequences like this, which will long outlast the conflict period that we are talking about. Now, these are obviously images from countries far away, and these are images from a town not far from where you guys are seated this afternoon. Now, that raises the question, when faced with that situation, how do we respond? Now, it's interesting, people respond to this situation in different ways. Some people develop a sort of resentment. Why did this happen? Who was responsible, etc. Quickly leading to blame and scapegoating, which are usually negative emotions and are not usually helpful to resolve that situation. But some people will decide to do something about the suffering, the human cost that is associated with this form of situation. So now what can we do about it? Obviously, stopping the war is a priority in which we may have a role, we may not have a role. We could get involved with groups to try and prevent its recurrence. We could get involved in the rehabilitation of victims so that the memories of the war, the consequences of the war can be lightened for at least for the people who bore the brunt of this conflict. We could work towards maximizing the social and economic opportunities that the victims of the war may have. And perhaps, in my view, more importantly, use the lived experiences of victims to prevent the recurrence of this form of conflict. Now, why is this relevant to us? We are doctors meant to look after people. Why is this form of activity relevant to us? And I'm sure some of you in the audience would think of meritorious reasons such as PIN or such as merit, etc., etc. But I tend to look at it from a more selfish point of view, because like the human body, human societies are what you call self-organizing systems. Now, a self-organizing system is a system which evolves through interactions between multiple independent units. If you look at it as a human body is the consequence of multiple cells and multiple systems which have all come together to form a human body. Similarly, a human society is where lots of groups of people have come together spontaneously to function as one harmonious entity. Now, a fundamental feature of self-organizing systems is that the well-being of the whole, the larger entity, is intimately and intricately and inseparably linked to the well-being of the component units. And the well-being of any given component unit is equally intimately, intricately, and inseparably linked to the well-being of the whole. Now, this is a very fundamental feature of self-organizing systems. Whether you think of the human body or you think of human societies or whatever, that is how nature or Allah or Tao or God or whatever you want to call it has created this self-organizing system. And therefore, looking after the well-being of another person or another community or another society or another individual is almost inseparably linked to my welfare. So there is a selfish reason as to why we should be thinking about these issues, in addition to the other altruistic reasons that immediately springs to mind. Now, here is a man who thought about this issue in that light. His name is Dr. Panagamua. Some of you may have actually been taught by him. He was senior lecturer in surgery at the University of Ruhuna. He migrated to the UK he changed his specialty to become a consultant in rehab medicine. And having been involved in rehabilitation of people in Sri Lanka, such as establishing the Ranavira 7, etc., he got involved in rehabilitating the victims of the war in Mannar Hospital as soon as the war ended in 2009. Now, starting from these very humble beginnings, this man almost single-handedly went on to establish a state-of-the-art prosthetic center here. This one here is in Mahava, in the North Central province. And this is a center which was put up by the OMI priests in Mankulam, where also he ran a very comprehensive prosthetic limb service to the victims. And I still remember when I asked him one day, Pana, why do you do this? There are other agencies that are providing this form of service. He turned back and told me, I will not allow my people to get inferior treatment in my own country. And that was a very powerful statement that he made. Now, more importantly, one of the innovations this doctor did was to establish a pioneering outreach prosthetic limb service, a mobile unit that went from this hub into the depths of the disadvantaged districts, whether it is Tunukai or Mullaitivu or wherever, and did this prosthetic and access these victims, and thereby was able to provide this essential service to a very large number of people within a very short period of time. Now, from here, my involvement with this set of activities was quite peripheral. I was just part of the group rather than doing anything very active. But because of that association, I was aware of this kind of activities or this kind of possibilities. And then, in my role as in the medical school in Manchester, I was sent to Uganda to establish an academic partnership in the areas of pedagogy, curriculum development at a university called University of Gulu, which is up in northern Uganda. And during a visit to the different parts of the hospital, I ended up in this place called the Orthopedic Workshop, where this form of activity was taking place. So a very quick inquiry into the background of all these things, because I had that natural interest based on what is going on back home in Sri Lanka, it transpired that they too in northern Uganda had a very protracted long war which lasted for about 20 to 25 years between the government forces and what is then called the LRA, or Lord's Resistance Army. So that led to the concept that we need to do something more about it. And it transpired that the magnitude of the problem was not known at the time, because the war in northern Uganda was a very, very rural war. It was fought in the bushes, and all the victims of this war were out there, not accessible to the healthcare services or the hospitals. People who came to the hospitals were just a tiny minority. So there was a need to estimate the magnitude of the problem, because that form of data is essential to plan a proper health service. We felt there was an opportunity to exchange professionals' expertise, experience between Uganda and Sri Lanka in developing this area further. And based on Dr. Panagamu's experience and the benefits it brought to people, we thought there was an opportunity to set up an outreach limb service based on Uganda, model on the Sri Lankan experience. And we were fortunate because there was a fund called the GCRF, or Global Challenge Research Fund, which was established by the British government at the time, drawn from the overseas aid budget in order to support people who wanted to engage in activities of this nature. And through a series of activities, we launched a program to establish a virtual center of excellence linking Sri Lanka, Uganda, and of course the UK as the coordinating partner. And in this partnership, University of Gulu, University of Ruhuna has been involved in lots of discussions related to this, and there is a bigger grant that is currently under review. And what I'm going to talk to you is the preliminary project that led to this big grant application. So the region that we are talking about, now this is Uganda, north of Lake Victoria here. And that is the Nile here that goes or starts from here and goes up there. And this is the region that we are talking about, this whole area. And the population here is very, very variable, because even now there are people moving from South Sudan and the DRC from here, so that the population is a very transient population. You don't know what the actual size of the population is. So there are lots of geographical and epidemiological difficulties in doing studies of this nature in this, perhaps the most deprived part of the planet as we have this discussion. So this is the area that we are talking about 29,000 square meters with about 2 million people, consisting of 8 districts spread across that land space. And this shows the population density. As I said, I won't go into the details. This talk is just meant to give an overview of the kind of activity that is relevant. So we planned a cross-sectional survey involving 8,000 households. And these households are spread across all 8 districts in the form of 100 clusters. So each cluster would have 10 households. The plan was to do a semi-structured interview of the heads of the household in the first instance. And when we identified a person with major limb loss, we would do a more detailed interview in order to identify the factors and circumstances and the consequences associated with these injuries. But the question is, how do we do this in a vast area with poor access, no road connections? How do we access these people? So we thought we could take a geographical approach and look at maps and do a random cluster sampling based on the maps. But at the time, the only maps that were available to us were these maps, which is constructed by the British Army in the 1950s or 60s, which it doesn't bear any reflection to what the area looks like currently because of all the movements that have taken place. So I approached a subject specialist in this area. The guy is standing there. His name is Dr. Jonathan Huck, or Johnny Huck. He is a specialist in GIS, or Geographical Information Systems, or Geographical Information Sciences. And when I approached him with this problem, he said, yes, we can construct these maps within fairly short period of time using GIS. And he went on to produce these maps. And the key thing is these maps were produced, these digital maps were produced by students, undergraduate and postgraduate students, as part of their day-to-day learning experience. Now, that's an important message. Here are a group of students who have come to do a degree program, and they're doing a project leading to an output which is actually going to help people in their day-to-day living. So that is a powerful way of delivering the teaching programs where the teaching is relevant to the needs of the society. So after many sessions and lots of pizzas being eaten, Johnny and his group came with maps of this nature, which we call VGI, or Volunteer Generated Information Systems Aided Mapping of Areas. And this at present happens to be one of the main ways in which maps where commercial mapping, or areas where there is no potential for commercial mapping, can be mapped. And I'm quite proud that that was published by one of the frontline geography journals. And that is a moment of great happiness to me personally, because having trained in medicine and anesthesia, to get a paper in one of the frontline geography journals was something I was really proud of. So using these maps, we generate, and using random or algorithms that were able to generate random geographical points across that whole area, we identified these 800 clusters into which our field teams went and to conduct these surveys. So because it was geographical, it is completely random. And the results, we managed to conduct about 7,900 interviews. And we found that in almost 50% of the households, there was at least one member who had some form of major disability. And we identified a total of 237 subjects, which projects to approximately 12,000 victims in this region, giving a prevalence rate of about 0.6%. Now, this kind of data is currently not available, and it's currently under peer review. And you really need this form of data if some form of rational service is to be implemented. So we went on to analyze the etiology of these injuries, and obviously, as expected, the majority of them were war-related injuries, and there are other NCDs becoming more frequent. But at the time of the survey, this was the etiological factors that we were able to identify in this cohort. We went on to look at the age distribution of the victims. These are the observed values, how the observed values were distributed across the different ages. This is what you would expect based on the population census. So if you look at the difference between observed and expected, this is what you find, implying that most of the victims were in the older age groups. And that is what you would expect, because we are doing this survey several years after the conflict came to an end. Similarly, looking at the gender, these are the observed values. This is what you would expect from the population census, and therefore the difference is a lot more for the males, meaning that most of the victims were males, and the differences are all significant. Right. When we looked at the educational attainment categorized into these three major categories: no education, primary education only, or secondary education plus, and look at their distribution within our study cohort and the expected values based on the census data, this is the difference showing a predominance of people with no education at all within the major limb loss cohort, showing that the lack of education was very apparent in the cohort who had lost limbs as a result of the conflict. We also did a distant analysis. Where do these people live in this region? Because the only prosthetic limb service was here in this place, Gulu Hospital. But as you can see, people are distributed in different clusters across different areas. So if this form of information is really, really essential for health planners, and that is the kind of data that we were able to produce using a population survey of this nature. We set up the outreach clinics based on Dr. Panagamo's model, which was obviously described and invented in Sri Lanka. But obviously our vehicle was much smaller because the roads there are difficult to access. So therefore it had to be this. And this is a cohort of about victims who received these services using this outreach model, who came back last year for a focus group discussion to share their experiences. More importantly, we conducted various public engagement activities using street plays to share, excuse me, to share the lived experience of the disabled people. We were focusing on domestic violence and workplace discrimination using a mixed cast of people, of able-bodied and disabled people. Now, changing attitudes towards disability is difficult to achieve by just factual information. By just giving facts, you're not going to achieve that. We need to touch people at a visceral level, at an emotional level. And when you want to do that kind of activity, art and music and theater and dance has a stronger impact than just straightforward factual transfer of information or transfer of factual information. And this is the kind of activity. Usually these are in some of the most remote villages in this part of the world, taking place under mango trees, usually engaging about 300 to 400 people. And this is what we call participatory theater. So the cast performs, and once the performance is finished, they would perform that again, but this time freezing their activities in certain areas, certain crucial predetermined points, so that the audience can engage and challenge some of the views or attitudes of people. So that's called participatory theater. And this is an example of using participatory theater in northern Uganda to challenge and address some of the views and cultural taboos that exist in relation to disability in this part of the world. So to conclude, our survey showed that the prevalence of disabilities in this impoverished region is about prevalence of major limb loss, not disabilities, as a whole. Major limb loss is about 0.6%. And this is the first ever estimate of the size of the problem in Uganda. And we established that health service provisions are grossly inadequate and a new service model is required. So we have conducted pilot outreach clinics, which have delivered a substantial number of limbs, and we have established expertise to be shared between expertise and experience to be shared between Uganda and Sri Lanka, which has been initiated and are ongoing. There is a need to validate if the outreach model is economically feasible, whether it is cost effective, whether it is acceptable, and the grant application I was referring to, which is currently under consideration, will address some of those important facets of the study. Now, I want to conclude by, before I do that, now, what is the wider significance of this to Sri Lanka? The concept of post-conflict disability is a pressing problem of our times. It remains long after the conflict finishes, long after the cameras have moved on, long after the NGOs have left the area. This problem will continue to remain. And the relevance of our study and the talk that I'm doing today to Sri Lanka is patently obvious. The question I would like to pose to the College of Physicians or bodies, similar bodies in Sri Lanka is, do we have a systematic approach to dealing with the disabled in the country, wherever they may be, whatever the group they may belong to? Because in my view, they paid the ultimate price for the political madness that we have lived through in our lifetime. Now, just to conclude with a thought from the great Buddha himself, is holding on to anger is like clasping hot coal with the intent of throwing it at someone else. you or we are the ones who get burnt. Thank you very, very much indeed.
Thank you. Thank you, Professor Nirmalan. Thank you for that excellent talk. Actually, you've done a great job as an anesthetist, and I think we have got a lot to learn about your efforts in Uganda to transport that into Sri Lanka. I don't think we have any questions because it's a plenary. And this concludes the plenary. Thank you.